So today we are going to talk about quinsy, okay? Quinsy or peritonsillar abscess. Remember, the crypts of the children is slightly superficial, but the crypts in the adults is slightly deep. That is why whenever we talk about quinsy, it is more common to adult on contrary to the children. That is why if there is a first episode of quinsy in adult, it becomes an indication for removal of the tonsil. We basically go for an interval tonsillectomy. That means we'll go for a tonsillectomy after 6 weeks, 6 to 7 weeks after an episode of peritonsillar abscess. Since the crypts in this area in the children's tonsil is superficial, that is why we wait for 2 episodes of quinsy. So if there is 2 episodes of quinsy in the child, then we have to go for interval tonsillectomy. Okay, now what we need to remember in contrast to peritonsillar abscess or quinsy, it is peritonsillar abscess occurs secondary to tonsillitis. It is a tonsillitis because of which there is a peritonsillar abscess, right? And what we need to remember is it's basically the infection from the oropharynx, infection of oropharynx, okay, of oropharynx, poor dental hygiene, and of course the infection from the other spaces can also lead to peritonsillar abscess. The most important cause is tonsillitis. That is why group A beta hemolytic streptococcus, group A beta hemolytic streptococcus becomes one of the causes for tonsillitis, for peritonsillar abscess. Of course, there is bacteroids also, and there are other organisms like other aerobic and anaerobic organisms also, but the major one being the group A beta hemolytic streptococcus. Now, what do you need to remember whenever we talk about quinsy is there is a classical feature of hot potato voice. Hot potato voice is also seen in the case of, see, it's also case hot potato voice is also known as muffled type of voice. These muffled type of voice can be seen in the case of supraglottic palsies, like it can be seen in the case of acute epiglottitis or retropharyngeal abscess. But understand that this hot potato voice, the start of this hot potato voice was started from the peritonsillar abscess. That is why this is taken as a hallmark for peritonsillar abscess. Now you need to remember that peritonsillar abscess, whenever we talk about peritonsillar abscess, the peritonsillar abscess is it's a dangerous situation. First we treat with IV antibiotics, and if that doesn't subside, then we will go for a medical management in the surgical management. In the surgical management, what we do is we just take two boundaries, one from the upper pole of the tonsil and the other from the lateral border of the anterior pillar of the tonsil, okay, and the outer and superior quadrant becomes an area for aspiration. Okay, this is the area of aspiration, okay, area of aspiration. Now let's talk about peritonsillar abscess. Peritonsillar abscess or quinsy, the idiopathogen is the pus present between the tonsillar capsule and the superior constrictor muscle. Initially also there was one diagram here over here. So this is a tonsillar capsule. This capsule is made by the condensation of the peritonsillar, it is from the buccopharyngeal fascia, okay, buccopharyngeal fascia. Pharyngobasilar fascia. This capsule is made from the pharyngobasilar fascia, okay, pharyngobasilar fascia, and this tonsil is a component of your Walder's ring. So basically peritonsillar abscess means there is an pus that is in between this superior constrictor and the pharyngobasilar fascia, okay. Now, pathology, both aerobic and anaerobic, as I already told you. Acute tonsillitis, blockage of the crypts, intratonsillar abscess, peritonsillitis, quinsy. What does that mean? That means, suppose this is your tonsil. So what happens is there is an infection. There's a pus that is over here. So this is either this is follicular or parenchymatous or membranous. So what is this? This is a follicular type of tonsillitis. Now this, from this follicular, it will go to parenchyma, okay, and this crypts will be closed and totally it goes to this space, and that will lead to peritonsillar abscess, okay. So one is acute catarrhal tonsillitis, where the tonsil is just red and reddish, okay, it's not enlarged. The second one is actually the acute follicular, and then you have acute membranous, okay, and you have there are different types of tonsillitis. We'll talk about that in that tonsillitis area, okay. And whenever we talk about this tonsil is a component of your Walder's ring along with your adenoids, as well as it is also a component of your adenoids, lingual tonsil, tubal tonsil, and the tonsils are basically component of your Walder's ring, right? So whenever we talk about the clinical features, it's a young adult. Why young adult? Because peritonsillar abscess are more common to children, whereas in the peritonsillar abscess are more common to adults, but whenever we talk about the children, in children the acute tonsillitis are more common, right? And they present with severe odynophagia, okay, difficulty swallowing. They present with halidosis, and they present with muffled voice. The muffled voice, same hot potato voice or muffled voice, okay. So paratonsillar area is swollen and congested, unilateral tonsillar bulge. If it's a tonsillitis, it's a bilateral bulge. Okay, don't confuse with tonsillitis. And of course, there can be lymph node enlargement, cervical lymph node enlargement may be there. The lymph node may be so much tender. Okay, there will be trismus and torticollis. Okay, trismus and torticollis. Trismus means difficulty opening them out. Torticollis means bendage of the neck. So torticollis plus minus, but trismus it will be always present with peritonsillar abscess. Okay, management, you can just go for a needle aspiration that reveals the pus. And medical treatment, you can go for urgent admissions and with IV fluids, and then you can go for IV ceftazidime and metronidazole. You can give antihistamines, and this is all given, yeah, this is very important. Okay, beta histine gargle, this is very 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 important. Basically you are going to go for a H2O2 gargle. Okay, H2O2 gargle, hydrogen peroxide gargle. Needle aspiration is done from, I already told you that one area is taken as a landmark, and the other area is over the roof of the base of the uvula. Okay, this is actually the roof of the tonsil, but it is actually taken as the base of the uvula. So base of the uvula, and this landmark is actually this is a lateral to the junction of the anterior pillar, and then you just inspirate it from here. Okay, this area. Okay, so from here we can just do like this and make it. Okay, see. So alternate incision sites can also be there, maximum bulge, but we have to understand that one. Okay, so incision is made. Surgical treatment is interval tonsillectomy. Okay, interval tonsillectomy. Hot tonsillectomy or abscess tonsillectomy is avoided as it leads to more bleeding and septicemia. What do you mean by hot tonsillectomy? Hot tonsillectomy, exactly at the time of peritonsillar abscess, we are removing the tonsil, and that will lead to massive bleeding, because you know that peritonsillar abscess is a inflammatory condition, right? Inflammatory infective condition. So there will be more vasodilation at that particular area. From your Robbins first year, very first chapter, inflammation and repair, right? So don't go for a hot tonsillectomy. So complication, they can be parapharyngeal abscess, retropharyngeal abscess, laryngitis, laryngeal edema, lung abscess, all the areas surrounding the tonsil. You can just write it down. Okay, that's it from peritonsillar abscess. Thank you everyone.